So high school biology, we have the chromosomes that we get from our mom and dad, and the 22, and then the sex chromosome, the X and Y chromosomes. P stands, I say it stands for petite, it's the short arm, and the long arm is the Q, and the centromere is the middle. So it's like two pair of pants joined together in the middle. We don't have to spend a lot of time on that because it's not really that relevant. Most CLL patients have some chromosomal abnormality. The most serious one is the 17th chromosome. The short arm of the 17th chromosome is missing. And why that's important is there's a gene on that makes a protein called TP53. And TP53 is called the guardian of the chromosome. And what it does is it looks around and says, this part of the DNA looks a little damaged. Let me see if I can fix it. Oh, I can't fix it. Let's make the cell die, in terms on programmed cell death or apoptosis or cell suicide. All chemotherapy works by damaging the DNA. But if you don't have TP53, the DNA can be terribly damaged, and the cell just keeps reproducing and making more and more weird offspring again and again and again. And that's why chemo, the traditional chemotherapies, don't work. In the TP53 if you're missing the 17p, you're missing TP53, and you don't do you used to, until the new drugs came along, not do very well with CLL. The new drugs are completely agnostic to 17p deletion. They do very well with that. There's other deletions. The 11q has, on it has a protein called ATM, and it's kind of complicated, but it does something like the TP53, but it's not as critical. You can have an extra chromosome that's called trisomy 12. You can be missing part of 13, and there's other ones that are less common. And the way doctors look at this is so the first test we learned about was called flow cytometry, which looked at the surface of the cell, proteins on the surface. This looks inside, and we use fluorescent markers. It's called fluorescent in situ. That just means inside hybridization. It just means done over and over again, that look inside at certain cells. You can see the normal pattern here on the left, and if you look at the green dots in the middle, you see there's one extra. So the 12th chromosome was labeled green with the fluorescent dye, and there's an extra one. It shouldn't be there. There should only be two, so that's trisomy 12. You can see here in the last one, we're missing the red signal. The red signal in this case is the 13q, the long arm of 13q, so that's what we're doing. So mutation is DNA damage. We talked about TP53, and the other test, which is done even less than the FISH test, is this IGHV, or sometimes it's called IGVH, just to confuse you. I asked the CLL experts, which is the right one, and they all disagree, and you will see papers with it spelled both ways to the day. I mean, even you go to ASH, and they use it different ways. I mean, it's so confusing, and then, but what that is it's a measure of the maturity of the cell, and this is a little confusing, and it's counterintuitive. So as the cells mature, this is an immunoglobulin. So remember, these are cells that role in life is to make antibodies, to make immune globulins. And they make specific immune globulins to say, oh, there's a streptococcus over there. I better make an immune globulin against that streptococcus, okay? And in order to make that, it has to mutate. It has to change, so it matches and recognizes the streptococcus. So having mutated IGHV is good. Having unmutated, you're immature, you're kind of promiscuous, you can relate to anything else, you tend to be more wild and procreate more often. That's bad. So actually mutated is better than unmutated, which seems counterintuitive when you hear about it. This test used to be very difficult to do, at least in the US and most of Western Europe. It's a pretty standard and easy test to do now. It's a test that's very underutilized, and it's very important because, again, chemotherapy doesn't work very well for patients who are unmutated. There's other tests too. So a very inexpensive test is beta-2 microglobulin. It's sometimes shorted to B2M. It's a protein, and it tells us what the volume of the disease is and how quickly the disease is growing. So it's kind of a poor man's test. This can be done. It's a relatively inexpensive test. There's other genetic markers, and you're not going to really see these unless you're in a research trial. These are not being used in clinics, in offices. If you go to a place like MD Anderson or the National Institutes of Health or some big research centers, if you see Pete Hillman, you know, at Leeds, they're going to do all these tests on you in a research trial. But generally, no community, not even a university center, is doing those tests here. One other thing that you may come across is complex karyotype. And that's when they look at old school way they stimulate the cells to divide, and they can look, and then they freeze them as they're dividing. And they can look and see what the chromosomes look like. And if you have more than 3 changes in the chromosomes, you have 11q, you have 17p, you have trisomy 12, all different cells with these different things, that's called a complex karyotype. That's not a good thing to have. It says that your cell is kind of mutagenic, it's changing a lot. And you don't want a cell, you want a cell that's stable, that's kind of not mutating and changing all the time. All right. So let's talk about management. So we're taught, you know, why do we encourage our patients to have mammographies? Why do we encourage people to have a pap smear, the men to have PSA, to have a colonoscopy or a stool test for colon cancer? Because if you catch cancer early, it's better, right? But wait a minute, we caught cancer and we're not doing anything about that. And it's interesting, when patients are told the news, you've got a cancer, as far as we know, it's incurable. I'll see you in 3 to 6 months. Bye. You know, it's like, huh? You know, are you really a doctor? I mean, there's two reactions to this. Is this crazy? Or, that's wonderful, that's great, I have cancer, but you don't have to do anything about it. But active observation is becoming actually more common. For prostate cancer, we're doing that, and other cancers, certain bladder cancers, we just watch it and see. Because, you know, if you're 70-something years old and you're diagnosed with CLL and you're part of that 20-25%, if a quarter of the people never need treatment, then what's the point of rushing in and treating them? Now, until EHA, the European Hematology Association meeting in 2019, which was just months ago, really, there's never been any evidence that starting early made a difference in life. And in fact, there was some early studies that showed that it might make things a tiny bit worse by intervening early because you were giving people drugs that they didn't need. But there was a study there that showed high-risk patients, so people with that 17p deletion that we just learned about, slowed progression. But there's still controversy about that. And people, you know, because there's no evidence that it actually makes people live longer. Would it work just as well to wait until they needed treatment and then start them on ibrutinib? I mean, sure, it's slower to when they need treatment, but if they're not going to live any longer, you might be putting them on a medicine for 5 years, and if you started in year 6, they live just as long. You know, so, and no drug is without side effects, and one of the common side effects of these medications is bankruptcy. So there's still no evidence of benefit of survival. So watch and wait, or active observation, or people call it watch and worry, are still the common way to treat it. So principles of CLL therapy, and this is my personal opinion here, and different people have different approaches, but generally these are following the guidelines. Prognostic and predictive testing should be done first to consider the best options. So let me talk a little bit about those two, because these words are thrown out there, and even hematologists sometimes don't get them right. So prognosis says how well are you going to do? And we know, for example, that people with 11q or 17p tend to have disease that moves more quickly. People that are unmutated tend to have disease that moves more quickly. Predictive says how likely is this therapy going to work? So we know, ironically, that 11q is a bad prognostic marker, but with ibrutinib, people with 11q actually do a little bit better than people who don't have it. So it's a bad prognostic factor, but a good predictive factor for 11q. But it's a bad prognostic factor for chemoimmunotherapy. So if you have 11q, you don't do very well with chemoimmunotherapy. That's why two things I have to say. One is you have to know what your prognostic and predictive factors are before you start therapy. And two, you have to have a hematologist who knows how to interpret them, because it's complicated. 11q is good for ibrutinib, bad for FCR or bendamustine. So you have to know these things. And I'll be blunt, even in the US, most hematologists don't know this stuff. They don't. 80% of patients aren't getting appropriate predictive or prognostic testings when they relapse. And I'll show some statistics on that. So it needs to be done first before treatment. You could argue that it doesn't need to be done when you're diagnosed. You could see, and that's a patient decision that has to do with the economics and what's available in your community. But it doesn't have to be done on day one. You can see what happens. But definitely before you say, I'm going to start you on this drug or I'm going to give you this IV, you got to do the test. Because if you're 17p deleted and you get chemotherapy, all you're doing is damaging the bone marrow, increasing their risk of other cancers, and you're not going to help their CLL in any significant way. So you got to do it before treatment, before every treatment. We have a motto at the CLL Society called Test Before Treat. So we only treat it when it becomes symptomatic. When does CLL need to be treated? When you have symptoms from it. The symptoms can be as vague as severe fatigue. People's fatigue will get better because this is a disease of the immune system. You have all these inflammatory markers called cytokines. And it's kind of like, and if you talk to CLL patients, like you kind of have a low-grade flu all the time. Like you're kind of feeling like achy and tired and sore all the time. Like you're coming down with something, like you're in the prodrome of something. And knocking down the disease burden can make people feel better. They feel very tired. So that can be a reason. Or you can have, like Lorna went over, all kinds of symptoms of fatigue, or you can be anemic, or you can have bleeding issues and stuff. It's time to treat. And new therapies are coming fast, and often the clinical trial is the best choice. And I'm a big believer that this is a shared decision making. Some people say, I don't want to take a drug for years. I don't want to be a guinea pig in a clinical trial. Give me the standard chemo that has a good result. That's fine if that's the person's choice. You know, not my choice, but that's the person's choice. So now we're experts in the words heterogeneity, okay? So what's going on there is that some people, like I say, never need treatment. You certainly don't want to treat those people if they don't. And again, when we talk about prognostic testing, you have to understand that we're talking about groups. So I can take 100 individuals and say 100 people with 17p aren't going to do as well as 100 people who don't have 17p deletion. But if you pull 2 people out of this group and 2 people out of that group, these 2 with the 17p might live longer than those 2 without the 17p. I can't predict for individuals. I mean, we've got people in our support groups who've had 17p for 7 years, never needed treatment. But when they do need treatment, you can't give them chemo. So you know, everybody's different. Now this one here is no curative treatments. That may be changing. And I'm not sure if we show this slide or not, but old school chemoimmunotherapy, FCR, fludarabine, cyclophosphamide, and rituximab. People are now more than 14 years, some people 17 years out. And what you've seen, and these are the people with the best prognostic and predictive factors. They're mutated and they have no abnormal FISH studies. So the best of the best patients, and they're young and healthy with good kidney and liver function, really the best patients you could treat. But if we look at those people, what happens is some of them progress, and then you hit about 55% aren't progressing and have no evidence of disease, and that curve flattens out and plateaus and keeps going out, and nobody seems to be progressing. And now that curve is staying out about 14 years out. That's starting to smell a lot like a cure. I mean, if somebody's 14 years out, we can't find any disease, and nobody's progressing, it's starting to look like a cure. But it's only for maybe 1 out of 7 patients that applies. We have patients who've had bone marrow transplants who are several years out, you know, some of them 10 plus years out, that are starting to look like cures. And some people are whispering that CAR T therapy might be curative. And some of the new therapies get the CLL at such a low level that people are, which is similar to the early data with FCR, are saying, could this also be curative? But it's way too early to say that right now, because, you know, you don't know you have a cure until somebody dies of something else. You know, that's the only, I mean, really, that's the only time you have a cure. And what's happening, again, mainly in the U.S., is fewer and fewer people are dying of CLL. People are dying of second primary malignancies. That's a big issue. People are dying of infections. And people are dying of Richter's transformation and other things like that. But fewer and fewer people are dying of CLL. I mean, last year I attended 5 funerals, all CLL patients, not one person died of CLL.
What does it mean to die from CLL? It's always side effects.
So what it could mean is your bone marrow gets so impacted that you're not making cells anymore, so you're so anemic, or you get an overwhelming infection because you can't fight things off. You die of these complications of CLL, or so it does happen, but it happens very rarely nowadays.
But the question is, all the other reasons for death are caused by the fact that they are CLL patients. So maybe
right.
The definition is not right.
Right, but if you have CLL and you get lung cancer, and the lung cancer kills you, the primary thing is going to be put down is lung. I mean, if you have diabetes and you develop gangrene of a toe and that kills you, it's the gangrene that kills you secondary to the diet. So it is a factor. I'm not denying it's a factor, but the primary cause of death is very few death certificates will say CLL nowadays.
And I think what's important is we're keeping patients alive longer with their CLL, which is maybe why we're seeing some more of these other things happening, right? Because the CLL used to kill the patient before they had the chance to develop a secondary cancer.
Right.
And I'm not saying that that's a good thing, but it's good that the patient is living longer, and now we have to look at what else is happening further down that line so that we can either prevent or treat those things earlier so that they don't kill the patient either.
So we're moving into a whole other area, which is kind of this survivorship. Now I've survived but what good does it do you to survive the CLL if you have an autoimmune complication or if you have a second malignancy? Because those white blood cells that we learned about, the lymphocytes, not only fight off the viruses, they fight off second cancers too.
Yeah.
And especially skin cancers are a big issue in CLL. So the fact that we are living longer gives us this chance to develop all these other complications. We also have a higher incidence of heart disease, but all cancer patients have higher incidences of heart disease and stuff. So there's all kinds of other issues that we have to be looking at down the line. So patients have a hard time accepting a diagnosis of an incurable cancer which does not have symptoms nor requires treatment. After the initial shock of diagnosis, they are faced with a series of dilemmas, confusions, or conflicting choices, which leads to stress. I mean, I mean, when you're given something, it's just human nature, you want to do something. You want to be active. You want to, do something to, how do I take control of this? I mean, you get a diagnosis of breast cancer, you have some decisions to make. Am I going to do this? I'm going to do that. And then you do it. I mean, you do it within weeks, and at the most a month. I mean, there's a pressure. Can I get this done? When can we schedule the surgery, the radiation? I mean, it's boom, 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 boom. You want to get it done right away. With CLL, it's like, all right, we'll do a little research. We'll look at. I mean, it's very stressful for patients. And believe me, if you see a couple different doctors, you'll get a couple different opinions about where to go. One of the lessons I teach patients about this is that you have to make life-changing decisions with incomplete knowledge and conflicting advice. You have to make life-changing decisions with incomplete knowledge and conflicting advice, because there is no right answer. There are some definitely wrong answers, wrong things that you should not do. Shouldn't get treatment without being tested. You shouldn't get chemo if you have certain things. But there are definitely no clear right answers. Should you take ibrutinib? Should you take venetoclax? Should you do this? Should you do chemo if you got the right markers? Depends on which doctors you see. Depends on what country you're in. Depends on what your insurance will cover.
And we do see within this patient population a lot of people making lifestyle choices as some way that they can try to control their disease. So they may adopt a special diet that they think will help. We see, I know when we've done CLL conferences with patients in my past career, and we would go in and we would ask, okay, so how many people changed their diet when they were diagnosed? And pretty much everybody in the room will raise their hand, and then you're like, how many people are still on that extreme diet? And the number of hands goes right down, right? Or people that decide they're not going to fly, for instance, because of the fear of increased radiation if you're in an airplane. Or the people, green tea is very popular, right? You'll hear a lot of people drinking a lot or taking pills that are compress the nutrients from green tea. So lots of people are doing those kinds of things, and it's mainly because they want to take some kind of control over their disease when they're not given other options medically to do that.
And I'll be presenting some data, some research that we presented at ASH on that, a survey that we did of US patients, and you'll see the vast majority of patients, when they're told watch and wait, it's not a passive time. Patients are actively involved, and I'll present some statistics and the different ages, different gender.
Can I say something, Brian, just before you move on? Just from a patient advocate point of view, when you're advocating for your patients, and this is really important, you're kind of hearing all the things that the patients have in risk of secondary cancers, so surveillance for that, but also when patients are diagnosed, I mentioned that they've no access to a psycho-oncologist to guide them. So what tends to happen, and actually this is where it's really important for the information days that you have back in your own countries, is that when the patients come to meetings, and this has happened to us on numerous occasions, that maybe a lot of young patients actually coming up and they use that sentence, "You don't know what you did for me today," because we explained all this to them. That because when they got their diagnosis, and they were just completely lost, because the healthcare systems are not catering for these patients that have chronic cancers and are being sent home. You have cancer, see you in 6 months. And then they're lost. We do see it on the forums all the time. So you're listening to all of this, but I hope you're picking up that point, that from an advocacy point of view, it's so important for you to give this information to the patients. Sorry.
Yeah. All right. So do you want to do some questions now, or you want to move on to the next?